Thank you very much. I'm really very happy to be here, and it's an honor to have been invited to the Portuguese part of the session, as well as the main session. And I have to thank the previous speaker for a really excellent overview of everything you can possibly want to know about HCM in 12 minutes. That was quite an enterprise. If I can have the first slide. My task here is to describe how we did our own registry, which is more a survey than a registry. I will go into the details now. First of all, I want to show you this is why we have a long-standing interest. This is an old map of Florence in both disarray and microvascular dysfunction. So now we know cannot be considered a rare disease, but there was a time when HCM was a rare disease, and all cardiomyopathies, when they were young, have been rare diseases and then progressed to become not rare, not common, say uncommon diseases. However, they used to be rare. For example, hypertrophic cardiomyopathy was first described as an exceedingly rare fatal disease. So physicians who went to medical school during this time and studied during this time in the 70s and 80s have read and perceived this disease and keep perceiving the disease as very rare, very fatal. Now, people who are studying now probably have the perception of what is contemporary HCM. These are the people who are now in their medical school or internship. But again, this is the prevalence of clinical HCM, 1 in 500. So it's relatively common. And the hidden genetic defect in the population is probably even more frequent than that. So again, because in the early 80s, 90s, the disease was still perceived as very rare, there was obviously no talk of clinical trials as we are beginning to do now. We still don't have the trials, but we are beginning to think about the trials now. In those days, it was unthinkable. It was just enough to have a diagnosis in patients sometimes. A lot of these patients were diagnosed as something else. So in 1995, we published the first report describing the Florence database at the time. In 1995, Franco Cecchi had already been following patients from the original initial experience of this very few patients coming to the center to a number of 202. So this is in almost 20 years, Franco had collected 200 patients. Now we're well over 1,000 because it's progressive. I'm sure that you have seen the same in your centers. So in those days, it was still a relatively novel concept that hypertrophic cardiomyopathy was relatively benign with regard to overall cardiac mortality and sudden death in outpatient population or in virtually regional population. This is mostly regional population at the time. Now we are a national referral center, but in those days, it was mostly Tuscany. And on the other hand, it is a disease that can impact substantially on quality of life because of all disease-related complications. So in early 2000, we were invited by the National Ministry of Health to take part to a large survey. The large survey was called Progetto Cuore, so hard project, not very original name. It was supposed to be a very large survey covering many aspects of risk profiling for cardiovascular disease in general, including obviously ischemic heart disease. However, they wanted to have a sub-registry looking at hypertrophic cardiomyopathy in particular, and they asked us to take care of the study. They funded it, and it was funded for a 2-year period enrollment. We could do as we wanted in terms of enrollment. There was no help, but no directions either, so we were pretty free. And we had little idea on how to do this, but we followed what was reasonable. So we obviously first contacted all the existing referral centers for cardiomyopathies, friends who were working on the same topic. Then we also contacted most of the local hospitals in the Tuscan area because that was where the region we were working on. And we also advertised via newsletters and at scientific sessions the initiative as well as the we put up a dedicated website where you could download the instructions and the data sheet to be completed and sent. We were asking centers to provide some hard copies in order to validate the diagnosis. Obviously not for the great referral centers, but for the peripheral centers, we wanted to have at least some evidence that this was really HCM and not something else. This is something you have to do and to think about when you're dealing with registries. It's much easier now because you can definitely ask for digital copies of the echoes and ECGs. And in those days it was yet not so simple. It was the sort of early web age. This was a simple downloadable document. It was like 4 pages. This is just a front page. As you see, it's very simple. It looks very ancient now. But it included, we tried to keep it as simple as possible, but still informative because we wanted to have some hard data. We didn't go for the very sophisticated data because that was unreasonable. And we contacted directly over 100 institutions, and as I said, we diffuse information nationwide. In the end, over 100 institutions were directly contacted, and 64 agreed, but 24 failed to send data within the enrollment period. This is something you have to keep in mind, because as Professor Tavazzi was saying before, observational studies are time-consuming, they're not funded, it's not based on voluntary work. So you must expect to have a probably 30% rate of non-compliance, even from people who do agree and would like to take part, just because they're busy. So in the end, we enrolled, and you see that the area is mostly central, because this is because of where we work, and so direct interaction was easier around the Florence area. Quite a lot of participation from northern Italy, not as much from the south, but still, the number of patients from each region was reasonably substantial, and overall we enrolled 1,677 patients. And the interesting thing is that obviously most came from referral centers, but we had almost 300 from centers who, like usually community hospitals with somebody taking care of cardiomyopathies, but no specific referral center, and also a little subset of 200 patients from little centers, outpatient clinics around the country. As you see here, if you just make a simple ratio here, it's less than 10 patients per center. So the real small centers, and this is something that was also very new, because this supposedly are the very unselected cases, although it could be argued both ways, because most centers tend to send you the most severe cases they have seen and may miss the mild cases, so it's really hard to judge. The main information was published in American Heart Journal in 2005, so it took quite a while from the end of the enrollment to the publications. And the data was interesting, although a lot of the data the hard data had already been published by other centers as well. So the low overall mortality, risk of heart failure, low incidence of sudden cardiac death. The core of the data was not terribly novel. But still, it was nice because we had nice epidemiological data for the whole country and from different type of institutions, suggesting that this, what we did see in our regional center was probably the same as most people would see in any other center dedicated to cardiomyopathy, and even in the non-dedicated outpatient clinic. Again, this is very interesting and thought-provoking still, because look at the very low incidence of sudden death, the much higher incidence of heart failure, and the very high incidence of events altogether, so all bad things, suggesting that this is a disease compatible with good prognosis, but definitely impacting quality of life in a major way. Of which this was partly expected. There was very little in terms of surgery performed. Only like 3% of patients had some invasive relief of outflow obstruction. This is due to the fact that obstructive patients, this was before the papers showing that obstruction is actually a determinant of outcome. So in those days, we would really only operate on patients who were in class 3, NYHA class 3, despite maximum refractory to maximum pharmacological therapy. Very poor surgical expertise around the country, very few centers who could do, and physicians were very afraid to send patients to myectomy. Likewise, there was very little in terms of ICD implantation. This is for another reason. This is because this is the early ICD era. I mean, the ICD was widely introduced in clinical practice only after 2000, so this was the very early ICD era, and indications were still reasonably restricted, so only 4% of patients had ICDs. And then subsequently, we did a sub-analysis of the survey looking at a simple but useful marker, which is atrial dimensions, showing that the atrial dilatation is a very powerful, in fact, probably the most powerful indicator of outcome in patients with hypertrophic cardiomyopathy, mostly related to heart failure. And this is because, obviously, as in many other diseases, the left atrium represents the overall hemodynamic balance of the left ventricle, and is really like I call it poor people BNP. It is a very powerful marker. So there is definitely much more sophisticated information you can get from a registry right now, but this is what we could come up at the time, and it did help us to perceive the changing profile of the disease. Obviously, this was an initiative with limitations, and I want to share them with you because I think it's always useful to learn from other people's limitations and errors. So first of all, Italy is a 60 million people country, so all we could come up based on epidemiological estimates was we probably enrolled only 1 to 2% of the whole Italian HCM population. So it's a small section of what we could expect to find looking at the whole Italian population. This is something to keep in mind because HCM is frequent. So even in a country like Portugal, thinking about an all-comers registry may be too challenging, and maybe sometimes it's wiser to focus on specific subsets that you may want to study more in detail, including, for example, end-stage, sudden death survivors, pediatrics, patients with heart failure symptoms that may be suitable for clinical trials. Trying to go for all comers may be too much, and maybe you are getting it's only a portion of the truth. But anyway, it's still interesting. The other limitation was, of course, as I mentioned, that our survey was performed at the dawn of a real revolution because in the year 2000, genetics started, ICD was introduced, and alcohol ablation was coming along in a major way. So we took a snapshot of a world that was changing, and that has changed a lot. So it is already an old picture. It was strongly biased towards referral centers because as much as we tried, we could not involve as many peripheral centers as we hoped, and that is still a challenge in cardiomyopathies. It was not a registry in the proper sense, in the sense that it was not updated, and we did not get subsequent funding and didn't have the resources to really keep an update on that, although we keep planning to do a 10-year follow-up, but this is still not happened. And Italians don't always do it better. So why you can do better in Portugal? This is my personal opinion, so maybe I'm wrong, but I think you have a chance of looking at a small territory and a reasonably sized population, so you can really get an extensive survey. There's definitely a lot more to be gained from the advances in connectivity and web technology, which wasn't available 10 years ago, not on the same scale at least. And obviously you have cardiac magnetic resonance, genetic screening, hopefully larger referral to surgery, and so more accurate, more natural history of operated obstructive patients. And then, so therefore you can really look at the milder side of the spectrum if you're interested in that, and have greater accuracy in diagnosing HCM, for example, excluding phenocopies. Phenocopies was also something that was not included in our registry, so Fabry's was unknown of, and so on. And also, I think in these 10 years, awareness has a lot increased, thanks to the growing awareness for cardiomyopathy specifically, but also because of the rare disease campaigns, which also took off in the last 10 years. And I think you can probably make a much better work than we did. Thank you.